Thank you, Nancy. My arrival in this world was a surprise. With no ultrasound available, my parents were only expecting a fourth child, not a fourth and a fifth, who are identical twins. I grew up in East Nashville, Tennessee, a neighborhood 5 minutes from downtown. If you visit now, you'll find a gentrified, multicultural enclave with all the best restaurants in town. In my youth, East Nashville was segregated and apart from the rest of the city. My father, Robert Churchwell Sr., was born into severe poverty in the segregated neighborhood of North Nashville. In World War II, he served tours in Europe and the Pacific. Back home, he graduated from Fisk University, one of the great historically black colleges. With a passion for writing, he became a pioneering journalist, the first black reporter for a major metropolitan paper in the South. Because Jackie Robinson broke the color barrier in Major League Baseball, my dad was given the moniker the Jackie Robinson of journalism. He was not welcomed into this profession with open arms. For years, he wasn't even allowed to work in the newsroom, but he persevered. Today, his fedora, French coat, electric typewriter are on display at the National Museum of African American History and Culture in Washington. And in Nashville, a magnet school is named after him. The fact it is an elementary school is fitting because of the achievements of my mother, Mary Churchwell. When my twin brother and I were young, she went back to school getting her degree from Tennessee A&I. She then taught at elementary school for over 30 years. Along the way, in addition to raising our family, she also earned a master's degree in education. I share all of this not only because I'm proud of my family, I share this so you can understand the environment I grew up in, a household where academic achievement was expected, where I was encouraged to forge my own path, knowing I had my family's unwavering support, where I learned to believe that all things were possible, that the only limitations were those I placed on myself, and that with these privileges came a responsibility to give back to my community. And the important question my parents would always ask was, what can you do to help? As a physician, my life's work has been a part of the dramatic change in how we care for patients. But we are at an inflection point on what we can and need to do to achieve the best care for everyone. When I started my career, most US cardiologists were in private practice. As recently as 2007, 90% were still in private practice. But by 2023, with the pandemic playing a central role as a reason for practice acquisition, almost 80% were employed by hospitals and other corporate entities. This profound change has contributed to the expansion of care and growth of health systems. Likewise, many hospitals created service lines, including heart and vascular centers integrated across associated hospitals. You can find heart centers from Mumbai to Stockholm to Indianapolis, with hospitals and institutes that treat and evaluate cardiovascular disorders, conduct research, and strive to continually innovate. This shift has been fascinating to witness and also to be a part of, and compels me to ask these questions that will frame the rest of my talk. Is this new landscape improving the quality of care? What has been the impact on health equity? And what do we need to do to prepare for what is coming next? Let's start with the first question. Is this new landscape improving the quality of care? When I started as an intern at Grady Memorial Hospital in Atlanta in 1987, I admitted heart patients to a cardiac unit we would now describe as bare bones. Curtain-separated beds filled with patients facing a variety of medical issues. Patients outside the city faced even sparser facilities and minimal access to most specialists. Agreements for transport between hospitals did not exist. Now fast forward 35 years and about 1,000 miles northeast of the Yale New Haven health system. We developed heart care protocols for patients along Interstate 95, the main highway along the eastern seaboard. These protocols determined which conditions could be treated locally and which required transport to Yale for a higher level of care. Let's look back at the evolution of new therapies and their impact on the care of acute cardiovascular events. As famously depicted in this Nabel and Brunwald figure, the last 6 decades have been filled with remarkable innovations implemented at the level of individual hospitals and health systems worldwide. These include the age of large clinical trials, evaluating new treatments for acute MI combined with the evolution of healthcare delivery, as well as other major discoveries including groundbreaking pharmacological and interventional therapies. These have led to a marked decrease in mortality for in-hospital myocardial infarction. From this alone, it seems clear the hospital system model is a significant upgrade. But we see threats too. Ischemic heart disease remains the single largest cause of death in countries of all income groups. Researcher Subeidani and team looked at trends in premature mortality for acute myocardial infarction in the US from 1999 to 2019, essentially the dawn of our new era of care anchored by hospital systems. The first decade shows significant improvement for these primary groups, white, Black, and Hispanic people. The age-adjusted mortality rate for Black adults was nearly cut in half. But across all groups, in the remaining years, there was a frustrating plateau of improved survival. We're seeing much of the same around the world. An evaluation of the global burden of cardiovascular disease by George Roth and associates is striking for the high levels of tobacco use and physical inactivity around the world. Their data shows that 17 and over 20% of the world's population is affected by tobacco use, physical activity, and increasing their risk for cardiovascular events. George Mentz's recent review of the global burden of cardiovascular disease shows age-standardized mortality rates have declined almost 35% since 1999. But the burden from cardiovascular disease has continued to grow. This study details that cases have nearly doubled since 1990. Over that same span, the number of cardiovascular deaths surged by more than 50%. So back to our question. Has the boom in hospital systems and cardiovascular institutes here and around the world improved the quality of care? Yes. Our in-hospital systems of care have reduced the mortality associated with acute myocardial infarction if our patients make it to the hospital. But growth continues in the number of patients outside the hospital with disease. Efforts to reduce long-term risk need to be focused outside the hospital in our neighborhoods and communities. Now, our next question. What has been the impact on health equity? There is a great commonality in the issues that lead to inequities in care across the globe. These include where we live, which has a large impact on access to care, what we can afford to pay for the care delivered, and the structures of class and social status created by historical and systemic obstacles leading to unequal care. How health systems address these social drivers of health will have a lasting impact on their communities. One example of health systems tackling the health inequities that occurred during the COVID-19 pandemic was at Yale New Haven. Let's remember that national data showed at its peak disproportionately higher rates of COVID-19 infection for Black, Hispanic, and Pacific Islander people. These death rates in these populations were sometimes double or even triple the rates among white people. But during the peak of the pandemic, mortality rates for those populations at Yale New Haven were better than the national averages for all groups. Why? First, we acknowledged that we didn't know how to treat this disease because, well, nobody did. The health system sought to create best practices for the management of hospitalized patients with COVID-19 and use the emerging data from each patient in an iterative manner. This led to using electronic health record system data to monitor in real time the impact of therapeutic decisions. Simply put, we found out daily what worked and what didn't work for each patient. We applied that knowledge with an aggressive path for standardization and decision-making for each patient, and worked to equitably optimize resources across the health system. It was, in effect, continuous quality improvement applied to every admitted patient. This example underscores the potential for impact at the institutional level. So what have we learned to help battle health inequities with systems of care? We must fight and conquer implicit biases that can influence how we treat patients. And we must optimize therapies and hold ourselves accountable to ensure everyone has access to the best care available. we must also continually look for ways to enhance our impact, such as leveraging technology and health information to improve results. The final question is, what do we need to do to prepare for what is coming next? Before we answer that, let's focus on a crucial component for finding the answers: leadership. I've had the privilege of knowing and working with many fine leaders. Two of the best happen to be my brothers, Andre and Kevin. We have on a number of occasions talked about what successful leadership should look like. Here's a recent conversation we had on this subject. An ovation occurred for the audience. So. From your perspective, how best do you lead? What are the things that you actually go back to when you're in that room with a cacophony of voices that are asking, what's the direction?
There's a grouping around a few things, and that is develop and sustain an insanely deep curiosity. Number two, recognize you want resilience. You need to fail and take failures away to build the next set of success. And then the other thing was persistence and high energy, a high level of intelligence, a high level of commitment and perseverance for long periods of time.
You learn more by failing than you learn by actually, quote unquote, winning. Just from the standpoint of being able to take a step back and try to understand what happened and how that continues to, I'd like to call it, fill your suitcase of knowledge. You have to sort of try to define, I think, what kind of leader you want to be. What type of leader fits your personality? What do you want to achieve in your leadership? Servant leadership is not leadership where you have a meeting and you're talking all the time.
Right.
That means Andre can't do this. But, you know.
Yes, he has a real difficulty.
Yeah, there you go. That's great. That's great, young man.
I think I heard a bell go off.
Exactly, yes. I think we would all appreciate that our parents were very much into education. Narrow it down to, it's okay to work hard, and it's okay to work hard at things that you love. Keith, you've always taken the view of being not just who you are, but someone who is going to take it to another level. And having the opportunity to lead this organization in the way that you're going to do is fantastic.
I am happy to be joined this afternoon by Andre and Kevin, plus our other two siblings, Robert Jr. and Marisa, as well as more people who mean the world to me, especially my wife of 35 years, Dr. Leslie Douglas Churchwell, our daughter Lauren, and her husband Adam. Thank you all for making the trip to Chicago. Now let's get back to that crucial question. How do we prepare for what is coming next? A presidential advisory published this year in circulation shows that if we continue on our present path, then many key clinical disease metrics will surge in the wrong direction by 2050. These cardiovascular health factors are issues that need to be addressed around the world. The 2023 World Obesity Atlas estimates by 2035, the number of people who will be clinically defined as overweight will top 4 billion. An associated economic analysis shows that the annual financial cost, if unchecked by 2050, will top $1.8 trillion in the US alone. These statistics on global risk factors and recent advisories should be a wake-up call for all of us. What can we do to ensure they do not come true? First, we must find more ways to aggressively treat hypertension, control diabetes, battle obesity, and treat hyperlipidemia with therapies that we know work, and continue to pursue new and innovative treatments. Next, with our partners in government, industry, and communities, we must find ways to improve the social drivers of health. Access to care is a universal problem, and while many countries have worked effectively to pay for health coverage for everyone, there is a worldwide struggle to provide adequate care for patients in rural settings and those with persistent social and economic challenges. And lastly, we must enhance the working environment for our clinicians, scientists, and nurses so they can become more efficient and continue to feel that their work is fulfilling. And we must also assure that the use of AI improves our ability to deliver quality care and improves the lives of our patients and clinical staff. We are facing a crisis. While a sense of urgency always looms over medical care, it feels as if the clock is ticking a bit faster and louder. For an example of how we can move forward and adapt, we really don't have to look far. At 100 years old and counting, the American Heart Association has greatly improved how we understand, prevent, and treat cardiovascular and cerebral vascular disease. A great example of this work has been the Get With the Guidelines program, which aims to close the gap between evidence, implementation, and equity for care delivery. Get With the Guidelines has made a national and international impact on how we can best treat heart disease and stroke. So I ask you the same question my parents always asked me, but with a little difference. What can we do to help? What can we do to help accelerate progress while at this conference? What can we do to help when we get back to our clinics and labs? And what can we do to help make a difference in our communities? None of us is expected to have all of the solutions, but I've learned that each of us can do something, and together we can play parts large and small to make a difference. And not only can we must. This ethos is beautifully expressed in those words etched into the tombstone of Jackie Robinson. A life is not important except in the impact it has on other lives. So over the next century, the American Heart Association's second century, I urge you to not just imagine what a healthier world could look like. I urge you to help lead us into that new and better world for everyone, everywhere. Thank you. Be well.